So we're going to transition now to Janet Dean, who is a pediatric nurse practitioner from Kennedy Krieger in Maryland, and she'll be talking to us about one of the most important aspects of care for patients with rare neuroimmunologic disorders, which is rehabilitation. And rehabilitation is not just a one-time deal. As she'll discuss, this is something that really goes on throughout your journey with the disease. So with that, I will turn this over to Janet and encourage you to speak into the microphone.
Okay. So I'm Janet Dean. I'm actually a pediatric nurse practitioner at Kennedy Krieger Institute in Baltimore, Maryland. Although our program is through a children's hospital, and so we can only have pediatric patients on the inpatient unit, but in our outpatient program, we have 3 adult physiatrists, and we treat adults with spinal cord injury. And we see both traumatic and non-traumatic spinal cord injury, and we have a very nice connection with the TM Center at Johns Hopkins Hospital, so we see a lot of patients with neuroimmunologic conditions, as well as MS for our rehab program. So I'm going to just talk about activity-based therapy, but more importantly, just let's get moving, and the importance of activity for patients with rare neurologic conditions. So recovery from conditions, there's a lot of things that you hear, particularly about TM, like, 1/3 get better, 1/3, get completely better, 1/3 have some symptoms, and then another third really have no recovery at all. You also can hear from the spinal cord literature, if you don't get better in 6 months, if you don't get better in 18 months, then you really have no hope for improvement. And we just don't find that to be true. We do know that there is plasticity in the nervous system, in the central nervous system, so that some neurorestoration is possible. That achieving significant improvements over time is possible, and so ongoing rehab for patients with chronic spinal cord injury is really important, or chronic neurologic conditions. We know that plasticity is activity dependent, and that you need to be active in order to see some recovery. In our program, we work on 2 paths simultaneously. We really want people to be functionally as independent in this process as they can be, and then we also want to promote neurologic improvement and recovery, and really also hope fosters success. We really have a very hopeful approach. So first I want to just talk about activity. That's the first word in activity-based restorative therapy. Healthy People 2000 is 2020. Every 10 years, the CDC, along with the Surgeon General of the United States, publishes guidelines for, it used to be exercise, and I noticed when I looked at 2020, it's now called activity. So you want to be there. It's really recommended that engaging in physical activity is one of the most important things people can do to stay healthy and to improve your health. And physical activity should include aerobic exercise, muscle strengthening activities, and also increased balance and flexibility. Adults should get about 150 minutes of moderate intensive activity each week, and children and teenagers should be getting an hour every day. And I can tell you my children and teens don't, for sure. So why is activity important to everyone? I was going to start there first. Pretty much now, activity isn't, there's pretty much nothing that activity is not important for in the research literature. It's helpful for decreasing your blood pressure and preventing heart disease. It's helped to control weight and metabolic syndrome or diabetes. It contributes to healthy bones, muscles, and joints. It decreases the incidence of colon cancer, increases longevity, cognition, decreases Alzheimer's disease, improves quality of life, reduces anxiety, and reduces hospitalization and physician visits. Nevertheless, 60% of all people don't get the minimum physical activity recommendations, and then people with chronic conditions are even at greater risk because they even have trouble doing sort of the routine background activities that helps with all these things. So like housekeeping and gardening and shopping, so people really get even decreased activity. So why is activity important to the nervous system? We know it's the basis for maturation of the nervous system, that activity-dependent neuroplasticity does exist in the nervous system, in the brain and spinal cord, and that repetitive activation of the nervous system below the level of your lesion or injury is important. There is literature saying that it's more important in establishing and maintenance of neuronal connections, so having the healthy neurons reach out and try and help the neurons that aren't so healthy. Formation of myelin, the myelin goes over neurons, and if there's no activity coming from below the level of your injury, then the myelin doesn't know where to go. So having activity going from below is important. And birth of your central nervous system does have its own stem cells. We aren't very good at sort of harnessing them to get them to work, but we know that activity is important for that. Why is activity important for individuals with spinal cord injury? So repeated near normal activity, both above and below the level of your lesion, is important for optimizing neural recovery and regeneration. We want to reduce some of those secondary health consequences and symptoms that Dr. Qureshi was talking about. And then we want to maximize your functional independence, no matter how much damage that you have. So what if your activity level is compromised below the level of your injury due to your condition? So some people are completely paralyzed. Some people just have weakness below the level of their injury. If you can move it yourself, that's great. That's the best thing. And so we're going to help you to be able to move those weak muscles better and make them stronger. But if you can't move them, then we're going to make them move for you. And one way that we found to do that is by using functional electrical stimulation, and it gets called FES or eStim. And it's the application of an electrical stimulus to the muscle and nerves below the level of your injury to promote function. And there's lots of different units that you can use. There's handheld units, and with those units you hook up a wire that has electrodes, and you can place them at different parts of the body. And the handheld unit usually has maybe four places that you can have electrodes, and you can place them at different places in your body. And it's generally used to help strengthen those muscles. And functional electrical stimulation means that you're doing activities while you're using those electrodes on. So we may be using them when people are working on transfers to help with their trunk muscles. The one on the right side has just electrodes on one side of the body because you can get scoliosis if those muscles are weak. So we can use it on one side to strengthen those muscles. And we can also use it at a different kind of a setting on the other side if you're having spasticity that's pulling you over, not necessarily weak muscles. We can use it to relax those muscles so that we can work to straighten the spine. We also use FES cycloergometry, and let me see if I can get a whoops, come back. See if I can get, good, I can get a video working. I have a couple. So the FES bicycle has electrodes that you place on the person in different spots, and then it has a computer that actually generates contractions in your own muscle so that it's your muscle that's pedaling the bicycle. Now, if you're weak and can't pedal a lot, it has backup for you, and it will help the bike go. But if what it is, and you can see he's pointing at his leg muscle, and you can kind of see that muscle. He's completely paralyzed, but the FES bicycle is stimulating his muscle to generate a contraction to pedal the bicycle. And what that means also, besides causing a muscle contraction to help reverse that disuse atrophy, you also can get a cardiovascular workout because it's your muscles that are actually pedaling the bicycle. It's important for neuromuscular reeducation, muscle contraction. You're actually building strength and muscle mass in your muscle. aerobic training. It's important. Patterning is really good for helping to decrease spasticity. And the bicycle is a very efficient way of getting a lot of muscles stimulated at the same time. It doesn't work any differently than the handheld unit does, other than it goes in a patterned movement, and you can stimulate many areas at the same time. The handheld units do exactly the same thing. They're just not as efficient, and they don't do patterning, so you have to take them off, and you do 20 minutes here and 20 minutes here and 20 minutes here. But they do the same thing. So the benefits of functional electrical stimulation, I talked about a lot of them. In kids, when kids have a spinal cord injury when they're young, they don't follow directions very well, and sometimes they just don't know what can move, and we don't know, and they don't know what can move and what can't move. So if we use electrical stimulation and they see their hand moving because we contract their muscles, they're like, oh, wow, well, maybe it does work, okay? So that's what we mean by, proprioceptive or feedback. And also we can add some sensory input sometimes can help too. It's important for bone mineral density. Patterned activity particularly is really good to decrease spasticity, and it increases circulation. So how is activity-based therapy different than traditional therapy? So traditional therapy usually is much more compensatory. If it doesn't worry about what you can't move below the level of your injury, we're going to help you just get really strong with the things that still work. And then we're going to use compensatory devices to make up for what doesn't work. In activity-based therapy, we're really trying to activate the neuromuscular system below and above the level of injury using patterned and non-patterned activities. We want to restore lost function as much as we can, and we minimize the use of compensatory devices and bracing. Not to say that we don't use them. Of course we use them, but we want to really try and encourage your muscles to do as much as they can and to do the patterns in a more normal way rather than abnormal patterns. So activity-based therapy, we take traditional functional rehabilitation, we pair it with surface electrical stimulation below the level of injury, and there are several key components that we look at, including task-specific practice, mass practice, weight-bearing and standing, locomotor training, aquatic therapy can be very helpful if it's available, and then we're really big on home rehab programming. It's not going to therapy twice a week is not really going to cut it. You really need to be having a program that you can do at home on a daily basis. And that really, besides cutting down on, increasing how much activity you get, it also keeps you from having to drive back and forth to therapy and can actually reduce some of the stress on families. So activity-based therapy can be used in any individual, but it's really, really important for individuals with chronic spinal cord injury. It used to be that there was no hope for recovery when you had a spinal cord injury, no matter what the case was. So here's your wheelchair, here, go home and, live a happy life as best you can. But we do know that we need to provide lifelong rehab and lifelong activity for people with spinal cord injury. So we're attempting to meet the, Surgeon General's minimal standards for activity, and we want to do a program that can be completed in about an hour a day, which is recommended. One of the keys to participating in an aggressive activity-based rehab program is the management of all those secondary health consequences or the symptoms that Dr. Qureshi was talking about. So we work really closely with our therapists, and your doctors should be working closely with your therapists to help manage these symptoms. So, if you're so spastic that you can't pedal the bicycle, and that's something that we think is useful, we need to work on managing spasticity. We sometimes have to make adjustments to help improve your respiratory status until you get more cardiovascular endurance. If you're having a lot of pain and can't participate, obviously we need to work on that. And all of these things work together because often increasing activity decreases spasticity. It can help to decrease pain, and it helps bowel function, that kind of stuff. So we can reduce some of the symptoms with therapy, so maybe you won't need to use quite as much medication. So key components I'm going to talk about. We already talked about functional electrical stimulation, and we use that with just about everything else we do. Task-specific practice is really important to provide neuromuscular education and improve recovery and functioning. And that's the kind of a lot of the functional things that you do. Core strengthening is vitally important for people that have weakness. If you have weakness in your trunk, it's hard to use your upper extremities. If you can't lift both hands at the same time and you're always falling over, you can't put your hands together. You always have to have one hand free. If you're trying to walk, if you don't have a good, strong core, it's going to be really hard to mobilize your lower extremities. So we do that, all that stuff. The stretching, mat work, transfers, dressing, bed mobility. And these need to be the things that are relevant to you. What are your goals? What is it that you want to work on, and what is that you want to accomplish? We also often have to break down the tasks. You know, people come in and say, well, I want to walk. Well, that's a great long-term goal, but we have to break it down into smaller tasks that add up to being able to walk. And so that's really important. And positive reinforcement is really, really important. So I work with kids, and it's absolutely vital for kids because it's hard to get them to do things if it's not fun. But my mom had her knee replaced and went through a lot of rehab, and one day she called me up and she said, I got 5 gold stars this week in physical therapy because I was able to bend my knee, you know, to the degrees that I was supposed to be able to do it. I just started to laugh. I just was laughing, and I was like, it works when 71-year-olds, just a little gold star on a chart, you know? So positive reinforcement is really important. So now I'm going to talk about massed practice. So perfect practice makes perfect. So this is one thing that our program works on a lot, is it's not good enough to just, you know, do things one or two times. You need to do it lots and lots and lots of times to be able to retrain the motor patterns that are still there, and to try and get rid of abnormal patterns and re-establish better patterns. So this is being done with electrical stimulation. So he's got electrodes on his arm, and they're using, and you can see the therapist has actually a trigger for the electrical stimulation. So she is actually triggering his grasp. So she has the trigger down, and when she releases it, he grasps, he moves it. So functional electrical stimulation can help to retrain those, and the hope is that we're re-strengthening those muscles so that in the future he's going to be able to do this without the electrical stimulation. And so these are things, people can have these handheld units at home, and you go home and you do this at home. The therapist will set this up and get you the right parameters and the right places to put the electrodes, and then you've got to go home and keep doing this over and over and over again. So standing and weight bearing. Standing we do with or without assistance from bracing, depending on what you need. If you have some ability to stand yourself. If you don't have any strength to be able to stand yourself, we're going to use supported standing. We use tilt tables that are tables that go flat and then that you just lay on, and it has a platform, and we just gradually raise that up, and that's usually used in more acute injury. And then we use also dynamic standers. So this little boy has got what we call a dynamic stander or a rolling stander, and this allows him to push the stander and go where he wants to go and in a standing position. So with children for rehab, you know, babies when they first are born, they are laying, and then they sit, and then they stand, and then they walk. And it's vital not just to physical development, but to their cognitive development also. So we know that babies that, young children with disability that don't have the ability to change their position, to get up, to explore a different level of their environment, have cognitive, they have visual spatial effects, they are less curious, they have more learned helplessness. So it's really, really important to get kids standing and get them independently mobile at a year of age when kids are supposed to start being mobile. And there are mobile standers available for adults also, and some adults choose to get them. So this gentleman is in a stander that is also mobile. And standing isn't just to be standing there. That's what, standers get, used to have kind of a bad rap, especially with insurance companies, because it was just like stand. But you don't just stand. We can take support away from you if your trunk is weak, so you have to do badminton and strengthen your trunk while you're getting good weight bearing. And with patients, we do a lot of using the Wii, and the kids love Let's Dance and, bowling and golf and all those kinds of things that we do. So benefits of weight bearing, upright positioning is really a normal position to be in, and people miss being in an upright position. I talked about cognitive development, bowel and bladder function, just getting upright, gravity helps. We can improve your range of motion. If you're sitting a lot during the day, you tend to get tightness at your hips, and you start to kind of look like the wheelchair. If we can get you in a standing position, we can really stretch out those muscles. Your heart has to pump harder if you're standing, because it's got to go farther. And people just like to be able to be up in a standing position and talk to people eye to eye. So it's really an improvement of quality of life. We also use standard gliders. So it's like an elliptical at a regular gym. And so it's got good trunk and upper body strengthening. You get reciprocal patterning, cardiovascular exercise. So this, you're pumping that. It's hard to do, and it gives you a cardiovascular workout. And then this really improves your range of motion at your hips, because you have to really get a good stretch on your hips. So that's really important too. So for people that have some movement in their legs, and we do some locomotor training for even people that don't have any movement in their legs, because it also is really good for strengthening the core when you do locomotor training. So we do it more in people that may never, don't have much ability to actually walk themselves. We always use it in kids, again, because I said it's hard for kids to know what they have and what they don't have. And when you get in an upright position and putting some weight on your legs, then they may have more movement than we know. So we're trying to give you partial body weight support so that you get some pressure on your legs, because then the signals that are supposed to be generated are generated. And people that can't move when they're laying on a table may have some even reflexive stepping movements that we can kind of work on harnessing. And there's 3 components. We do treadmill training with partial body weight support or not, depending on how much you have. And then you want to translate that to overground and community. So some of the benefits of locomotor training is, if you have difficulty with walking, we can increase your walking speed, endurance, and independence, improve balance. We can improve the symmetry of your gait if that's abnormal. We'll improve the gross motor strength in your legs and improve motor recovery. And we do this land-based. So the one on the left is a very fancy FES stepper that has a huge amounts of leads that you can put on. It's got at the trunk and all along your legs, and then it actually helps with generating a stepping movement with the functional electrical stimulation. And then we also do a lot of locomotor training in a pool setting. And again, water is partial body weight support, depending on how much water you put in the pool, is how much the water buoys you up or not. So we do a lot of treadmill training in the pool. Then you want to translate that to overground walking. So we do a lot of walking with patients with bracing. And even people that have no movement in their legs, if they would like, can use bracing. It's quite extensive bracing. It's takes a lot of energy to use. But some people really like to be able to do that. The boy on the right had transverse myelitis when he was about 10 or 11, and he has his transverse myelitis is more flaccid, and people with flaccid spasticity muscles don't respond as well to electrical stimulation. So we really had difficulty trying to help him exercise. And he was kind of a little dough ball boy before he got transverse myelitis, and afterward, with decreased activity, it was really hard for him not to gain weight. And so he walks in these braces called reciprocal gait orthoses that, when he shifts his weight, it kicks one leg forward, and then you shift your weight, and it kicks the other leg forward. But he was able to lose weight by using these braces. So we were able to activate his nervous system and activate him better with this type of a therapy. And with little kids, we can get almost any little child walking in some manner, even if they don't have voluntary movement, because they're easy to brace, they're light, and we can do that quite easily. And then, the ultimate goal is community ambulation. And this young man is a paraplegic, and he's worked really, really hard. He has some movement in his hip flexors. And so we have him braced, and he's walking with a walker, and he's using the walker for compensation, and he's using all the muscles that he can. And he was able to walk across the stage for his college graduation, which was a goal that he had. So aquatic therapy is great. We can use it to help facilitate all the goals, of mass practice, patterned activities, and things like that. But the good thing about aquatic therapy also is we can use resistance. There's jets in the pool, there's treadmills, and the water is warm. So for persons with spasticity, they can get good muscle relaxation. So we can do gait training better in the pool for people that have a lot of spasticity. And for people that have quadriplegia and you can't really move anything against gravity or their arms against gravity, if you put them in the pool on their back and gravity is eliminated, you can move your arms up and above your head and do a lot more things that way. So home rehab program, I talked about that. What we attempt to do is get equipment and stuff into your home so that you can do your rehab at home. And so common things that we use is the electrical stimulation unit. We like to try and get FES bicycles. And the FES bicycle, by the way, you can do upper extremity also. There's upper extremity pedals that you can use. And then we like to get standing frames into the home, either a mobile frame or a glider. Considerations that we make for that are, what's your level of independence? One thing about I should mention is the FES bicycle and the standard gliders and the mobile standards for adults in particular are made so that they go, the FES bike, you drive your wheelchair, if you're in a wheelchair, up to it, move the footrests, and then strap the FES bicycle so you don't have to transfer. So that really helps for, caregiver, to decrease caregiver burden. The other, the standard gliders and the other standards, the ones for adults, you transfer at a seated position and strap in and then pump up to a standing position. So again, trying to minimize the amount of caregiver burden that there is, and so to make rehab available to people with mobility deficits. And then insurance, of course, is always can be a big barrier. Insurances are getting better at providing some of this equipment in the home, especially when we start making cases that you have, that activity is important for preventing all kinds of other conditions. And so we really make that case. I've written about the ultimate couch potato. If you're quadriplegic, and you can't move anything, you have no ability to exercise, you're going to have more difficulty with secondary conditions. And none of this equipment, though, I will tell you, will you get with that first letter of medical necessity and prescription from your doctor. There are at least 3 levels of appeal, and we go through every level for almost every patient, for every piece of equipment. So you have to really work hard to get it. And then another reason for trying to get equipment in the home is that insurance policies are often very limited in how much rehab that they'll pay for. So you may have 30 visits a year or 20 visits or 15 or 60. And so if we can spread the visits out and have you do work at home, then we can continue to kind of monitor your progress and update your program. So all work and no play. I think it's like all work and no play makes Jack a dull boy. So endless therapy is not very much fun, and nobody wants to pay for it, and nobody wants to do it. So as I was saying before, therapy should be focused in bouts. It should be goal-directed. What are the goals that you have that you want to work on right now? Do you want to learn how to get dressed? Do you want to improve your muscle strength in your lower extremities? Do you want to work on ambulation? All those kind of things. So we look at those specific goals. We look at what you're doing now, and then we will update it. But we know that activity-based therapy, or this kind of therapy, or all these components may not be available everywhere, although more and more and more people are centers are moving more toward activity-based therapy, including more electrical stimulation. And we present at conferences all the time. We did a training at the last TM Symposium. Our therapists came, and I think they had a showing of about 5 or 6 therapists that came, and they did a full-day course on activity-based therapy. So we're trying to spread this as much as we can. But if that kind of stuff isn't available to you, then get moving, So I just kind of Googled around in the Denver area, and there are exercise trainer-based programs, and they're usually personal trainer-based. There happens to be one in Denver that I saw, and they do have electrical stimulation equipment, and I see that they have the standard glider, and then they have other exercise equipment that's more like a workout in the gym. So these programs can be helpful. Unfortunately, they're usually out of pocket and can be costly. But again, you can use these programs to help you develop a home program. You can trial equipment and then work with your physician to try and get equipment at home. They also have a lot of these places, and we do even at Kennedy Krieger, have an open gym, so you pay a membership, and then you can go and use the equipment just like you would go to a gym. So there's more and more of these programs that have popped up all over the country, and it started as part of Project Walk was kind of the first of these programs in California. So those are around that you can find. Adapted sports. So we're just about, the Olympics are going on, and we're just about to go into the Paralympics coming up here, and this is just the logo from the regional Rio Paralympics. They start right after the Olympics are over, and there's all kinds of different sports, and all of the sports that are in there aren't things that are necessarily they do it in a competitive basis, but there are sports like archery and sports like fencing, and that don't take quite the same amount as wheelchair racing that people can get involved in, and whether you are whether you're interested in joining a basketball team and competing, or whether you're more interested in doing individual sports such as skiing. Out here in the West and in Colorado, there are lots of adapted sports programs, and almost every ski resort has adapted skiing, and they also have adapted summer programs. So there's a lot of things out there, and people can just try different things and see what makes them happy and what they think is fun to work on. There's other adapted activities if you're not quite so interested in those kind of sports. There's adapted yoga, there's horseback riding, therapeutic horseback riding, ballroom dancing. They do ballroom dancing with 2 people in chairs, and ballroom dancing with 1 person in a chair and 1 person not. You can bowl, you can do archery, hunting, shooting, all kinds of things that you can look at that can be adapted for either in a wheelchair or just for people with weakness. Other things, adapted cars. I just throw this in because I was talking about kids with having to have early mobility, and it's really, getting wheelchairs for really young kids is pretty time-consuming at the very least and difficult. So one thing that we can do that's become quite popular is the Go Baby Go program, and there's places, it's volunteer groups that will adapt just the regular old cars that you get for a couple $100 at Toys R Us, and this is a picture of my son's robotics club is adapting these cars, and this is one of our patients. And so it can be as simple as moving the gas pedal you use with your foot. They usually move a big red switch up to the steering wheel that kids can push and steer. And they do things like we have cars that you have to stand up to get the car go, So you have to get your butt off the seat and then the car moves. So when we're trying to encourage kids to stand, they can be modified so that you need to use a headrest if your goal is to keep your head up, or if you don't have enough movement, in your arms to be able to do that. So this is something that's been really important for kids. And again, to get kids out, and they go in, these little cars will go in the grass and places better than wheelchairs will. So that's something that's just been really fun to work on with kids. And then for big kids too, adapted cars, providing you with independent mobility to be able to get out, go to therapy yourself, do things yourself. Even, adults that have had attacks of, TM and are unable to drive in a regular way often say they just feel so much better when they get back to driving again and really are more independent. So I thought I'd throw that in. And then I somehow I had updated my slides, and I downloaded somehow the wrong version, but in the Paralympics, there are 7 people with TM that are going to be competing in the Paralympics in Rio. And there's going to be a TM Association blog that is going to come out on their website that's going to talk about all those people. And one woman, Amanda McGurry, that we met, she came to TM camp, and she is a Paralympian wheelchair racer. And so she got TM when she was 5 years old, and she started participating in adapted sports when she was 12, and totally just changed her life. She played basketball, and all through her high school, she got a full scholarship, a sports athletic scholarship, believe it or not, to the University of Illinois at Champaign-Urbana, and she competed there on the wheelchair basketball team, and then after graduating pretty much got involved in wheelchair racing. And so she does marathons, and she came to the TM camp to talk with our kids. It's very inspiring and very great for kids to see what she can do. And she's a complete paraplegic. So that was really fun. So she'll be competing. She has a gold medal, I think, from Beijing, and she's got several other medals, and this will be her 3rd Olympics. So particularly for kids and young adults, really, getting involved in adapted sports can be just a really great thing. So that's all I have for today. I'd be happy to, I think I have a little bit of time to answer some questions, if anybody has any. Yeah, I knew you were going to have questions. Exactly.
My question is, every person, they took out the wall of the step. Mm-hmm. They did not replace it. They did the stone rubber.
Yep.
My question to you is, can he get in this standing frame now?
We do get patients in the standing frame, even with that. And sometimes what you have to do is if there's a leg length discrepancy, you have to accommodate for that. But yeah, your therapist should be able to help. The thing is your bone density goes down when you are not weight bearing. So it's sort of a vicious cycle. Standing in a stander isn't a miracle cure for sure, but getting weight bearing is a good thing for a lot of different reasons. But being able to stand. The other thing about bone density is there is treatment for osteoporosis or disuse osteoporosis, and sometimes medications can be used, and we frequently use the bisphosphonate medicines, and it's the same medicines that are used in postmenopausal women. It's the same medications, and so you can be evaluated, and then they can figure out which medicine might be the best for your type of osteoporosis. So that might be something to consider. And it's not, many people with spinal cord injury have osteoporosis, and even women, and you never break a hip or never break a bone. So there's some discussion about whether to treat or not. The thing that we do know that most people sort of agree on is if you've broken a bone one time, you're probably likely to break another one. So that's when we really encourage people to get treatment to see if we can increase their bone density. Yes?
Is there any benefit for someone who has mobility using an FES cycle, the fact that it has stimulation?
So it depends. So I probably wouldn't, if it was a perfect world and people had just some weakness and could tolerate the FES bike, I probably would get one for them, but they're very expensive pieces of equipment, and so there's probably better things that we could do, like locomotor training or things like that, than to purchase that expensive piece of equipment. Also, if you have sensation, you may not tolerate the FES bike because it's literally it's shock, and when you get it up to the amount that it takes to cause a muscle contraction, most people don't like it. A lot of people tolerate it, so especially guys, they just think it's cool, ooh, that's so cool, and I've had kids, I've had people that had TM when they were young, like I see kids, and they come to me as teenagers, and when I do an exam, they tell me that they have normal sensation, and I used to tell the therapist, don't even bother with the bike because they're not going to tolerate it. Not true. It's sometimes when it's been a chronic issue, it's just the perception is different. And so while they may perceive that they have normal sensation, it may not be quite normal, and they may tolerate the FES bike. So we always trial things. Mm-hmm. Yeah, so another way to use functional electrical stimulation is like as an orthotic substitution. So there's ones that help with gait, and there's different kinds of equipment that you can use, and it stimulates the muscle to help pick your foot up or pick your leg up, but they take a lot of work with your therapist. So you might want to see if you can you could like even call the company and find out where somebody, so they're just, so they're using that. So what I would, if you think that was helpful, the MP unit wasn't really designed to do that. There are units that are specifically designed to do that, and it might be worth being evaluated for a real unit, and one's called the Bioness and one's called the WalkAid. And so they are available. Again, they're expensive and it's difficult to get insurance to pay for them, but we make a case that maybe it decreases falls and things that could cause a lot of problems. But the MP, I forgot that they even had that foot switch, but it wasn't really as sophisticated as some other units. Yeah.
Our son has his right leg. He just post brain injury, and then he now has his foot goes out a lot. It's getting much better.
His foot does what?
I thought it was just getting out, but apparently it's lifting his foot up and he's tripping on my grass.
Right.
We went to physical therapy this week, and they recommended some type of brace that I think lifts the foot,
Uh-huh.
whatever it might be, because he's compensating by turning his foot
Yes.
outwards, etc. And he doesn't want the brace because it'll track him into about it. Part of me was wondering, given that a lot of this is just rewiring or rebuilding pathways, like someone running with him every day for 10 minutes, or like, have you seen progress if you just repeat the action?
Right.
Reinforcement inside his foot?
Well, that's the thing you don't want to do. So you don't want to retrain you don't want to retrain bad habits. You want to make sure you're retraining good habits. And so, even if he doesn't want to wear the brace to school, but if you could get a brace and maybe do what you're saying, like go walk with him in the appropriate position to be able to retrain. Does he have spasticity? No spasticity. Okay. And
Normally you wouldn't notice, but like he'll fall twice a day or he'll, so it's just, he's at baseball and you can't notice, like it's showing up in ways
Right.
that we
Right.
notice, but most people wouldn't.
right.
But it is impeding, we feel safety issues, because he's always pretty involved here. So it's creating psychological issues.
Right. So I think if I were you, I would pursue the brace, even if he's saying he doesn't want to wear it, and it may be true that he won't wear it, but I say it's at least worth pursuing it once, because if it makes him so he is more comfortable and able to do some of the things that he wants to do better, he may decide to wear it. So that's what I would do. I would go ahead and move forward with that. And it's at least worth doing once. And then making sure that they're getting a brace that's therapists need to figure out what braces are the best, but some of the carbon fiber braces that they have these days are, may or may not be appropriate for him, but are sort of more energy storing, and not so big and bulky and plastic. But again, it depends on what what the issues are with him. He may need to keep his foot straight. He may need more of a bulky plastic, Yes.
Could you tell me, I have a walkie, and one thing I like about it is it's so big I can't wear it. So I have to look at it all. And if I don't get it in the right place, and I can never find the right place, what's your experience with the walkie? They are expensive, but
Right. Yeah. So some patients find them to work well and some patients don't. And I think, but again, they need a lot of readjustment, and, it just may be worth, again, going back to a therapist and seeing if they can help you get it positioned better. Sometimes they are in the closet after they get them because they just don't work as well as people would hope they would. And it doesn't completely fix a gait. But they're finicky and take a lot of, kind of messing around with to get them in the right place. And if the stimulation is too high, it can sometimes bleed over into other areas. And so you have to get it just right. Yes. So if you just type in Go Baby Go University of Delaware and go to the website there, and there is a Go Baby Go Facebook page, and so you can go on there and see a lot of pictures and a lot of groups that are doing stuff. The Go Baby Go University of Delaware, I went there and looked at sites, and that was the site I saw closest to Denver for that Go Baby Go program. Yes.
My nephew got TI back in January.
Uh-huh.
And can you tell us the difference between the spasticity and actual movement? Because sometimes he'll stretch out. He's only 2, he's just trying to one.
Right.
And then he'll go back into that throbbing position in his legs and kind of relax us. So we don't know the difference between actual spasticity or is it actual movement?
Yep. It's a problem. So, no, I mean, it's really difficult with 2-year-olds. We just really don't know. We know that if you have spasticity, people do have movement patterns, so they tend to go all out or all up. But it's hard to get kids to show us what they can do. And Yep. And my guess is that it's muscle spasms or spasticity. But but that's a good thing because it tells us that his nervous system is intact below the level of his injury. It's just that the signals aren't getting through between his brain and his muscles. And so spasticity is activity. It's activating your nervous system below the level of injury. So it's good as long as it's not getting in the way of things. We like to see kids with spasticity. The thing that you need to do, though, is make sure that we're managing it and make sure that it's not causing abnormalities down the road. If his muscles are spasming and they're very tight, then they can cause difficulty with being able to straighten your leg out. They can put torsion on bones as he grows. So he just needs to be monitored very closely. Has to have the right bracing and orthotics equipment, the right standing equipment, and things like that to make sure that we prevent complications of that spasticity. As he gets older, he may be able to use that spasticity. And that movement that he has, you may be able to train that into stepping patterns. Hey, thank you.